Welcome to the EAU podcast. In this episode, the panel chair of the EAU guidelines on prostate cancer, Professor Philip Cornford, talks to Dr. Ursula Vogl on genetic testing for prostate cancer. This EAU podcast has been developed with financial support from Pfizer Inc. for healthcare professionals based in the EU and UK. The content discussed here was up to date at the time of recording in June 2024 and may not be suitable in your local market. The EAU has retained full editorial control.
Hello and welcome to this podcast on genetic testing in prostate cancer. We're at the Onco 2024 in the middle of a thunderstorm in Budapest. I'm here with Ursula Vogl, a medical oncologist from Switzerland, and we are going to talk about the options and the role for urologists in genetic testing and prostate cancer. So Ursula, can you tell me something about why genetic testing is important for men with prostate cancer?
Well, we have potent drugs now that target those variants, alterations, mutations that we could find when we test. And genetic testing is a very broad name. So this is also when I did my presentation, we have to separate between testing on tissue or circulating tumor DNA. So this is called somatic testing. And then the germline testing, which should usually be integrated in a genetic counseling. So a deep information on why we do this.
And so what's the difference then in chance of finding something between tissue testing and genetic testing?
Well, it depends on the course of the disease. Some patients have a long story of prostate cancer. And then we have the tissue, the paraffin tissue from, let's say, 10 years ago from prostatectomy. Then they might have had a local recurrence. Then they might have had metastatic disease. And then we come to castration-resistant metastatic prostate cancer, where actually we want to know what happens in the tissue. So we have to find the right moment and also the right material where to test on. So the one thing is the tissue, so the somatic, and then we look into the genes of the patient, which has also a consequence for family members. And we should ideally do both. And we go more into depth why we should do both.
So let's start with tissue testing, because as a urologist, that's perhaps where we get more involved than anywhere else. So when should we do tissue testing for men presenting with prostate cancer? Who should have it?
Yeah, tissue testing is useful if we have a consequence. So if we have a drug in a certain setting which is approved, which is available, we should have the information. And of course, it's always best to be one step ahead and not to be confronted with the decision what treatment comes and then don't have the information on the tissue outcome. So since we have the PARP inhibitors, or actually olaparib approved in mCRPC as monotherapy, after one line of an AR-targeted agent, we should do ideally testing before first-line mCRPC on tissue. If we are lucky to have also a biopsy from a metastasis, this would even be more recent tissue and not from the prostatectomy maybe or the biopsy years ago. And then we have new approvals now in combination with AR-targeted agents, PARP inhibitors already in first-line mCRPC. But this is the setting where we should get the information from the tissue. I personally, and also the EU guidelines, actually recommend testing already in metastatic hormone-sensitive disease.
Okay, so just explain a little bit about why testing when the tissue is fresh is better than waiting and going back to those paraffin blocks you talked about.
This is what my pathologists always tell me. Well, and then you get a call and say, well, that prostatectomy tissue is more than 10 years ago, and the material and the quality is simply not good enough to do tissue testing. And then you might miss some genes, and these are white panels that we're actually using. There are more than 50 genes actually that are recommended to test. And then if the quality is not good, you might have a false result. So actually there are results and studies that say if the tissue is older than 7 to 10 years, you might consider doing a fresh biopsy. Or if it's not feasible, sometimes we have only bone metastasis, sometimes difficult to test. You can also go for testing on circulating tumor DNA.
And just sticking with tissue for a moment, what's the chance of getting a result, let alone a positive result, but the chance of actually getting a result? Because one of the problems here is that you can send your tissue off for testing and they just say it's inconclusive. We can't actually do the test, isn't it?
Well, I think that with the new tests and they're all actually approved and tested, you have a high chance, if the tissue is not too old, to have a significant result. So I think false negative results are really, really low if the quality is good. If we trust the pathologist, they know, and also the system and the technique tells when the tissue is not valuable in the end.
So what do you think is important for urologists to be able to contribute to this?
Well, in tissue testing, maybe less. I mean, there are urologists, of course, that also do systemic therapy, that treat metastatic patients. But for the somatic tissue testing, less, because as we talked, it's in metastatic disease. But also helpful is always the family history. Because if you already have a strong family history in the beginning, before you go even talk about germline testing, this is already useful information to say, well, we should push and see what's going on the tissue and the tumor concerning alterations or mutations.
And it might be worth mentioning that it's not just BRCA we're interested in, is it? We think about BRCA and we think about families with breast cancer, ovarian cancer and pancreatic cancer, but there are other conditions that we need to think about genetic testing for.
Absolutely. So I just recently had a young patient with a Lynch syndrome. So we should also go and look for microsatellite instability, for example, which is easy. You can do it with immunohistochemistry. It doesn't even need an NGS. And this can lead us to that need to test when we know there is a story of colon cancer or even upper tract urothelial cancer, or the patient has already his second tumor.
And there are treatment options that are specific for people with microsatellite lesions as well.
Absolutely, yeah.
So if we move on to genetic testing, in your presentation you talked about the importance of doing both. So I completely understand that if you've got a tissue abnormality which shows that you've got a mutation, then it's important to work out whether that developed in the cancer or if it was a genetic mutation, because that clearly will have influence for family. But why do we need to do both otherwise?
Well, we know from large database sets, and recently also the group from Elena Castro demonstrated that actually, as you first mentioned, if we do germline only, then we would miss a lot of mutations. There were about 30% of patients that have somatic mutations on tissue, because it then can develop during the course of disease, and also vice versa, but a lower percentage. If you have a negative somatic tissue test, there's about a 5%, 10% chance that also when you germline test, find a targetable mutation. So ideally, do both, but we know there are limitations.
Yeah, and I think in the clinic, we've noticed that there is some reticence for germline testing amongst patients. What's your experience?
Well, we're collecting the data at our center, so we're lucky at the JOSI in Switzerland that actually costs are covered. We have qualified also genetic counselors. My genetic counselor is also oncologist. You can also do a genetic course, a training. So I could also do genetic counseling, but I think it's a matter of experience. So we try to send the patients to one or two persons that do it every day. And we've seen when we oncologists or radiotherapists or urologists announce the patient, well, we will send you to the counselor. And then they say, yes, that's fine. And it's always not urgent. So they do it in the next month. And then the call comes back from the secretary saying the patient refused to come because he doesn't see the sense in it. And so I think in prostate cancer especially, less patients accept genetic counseling and testing because they don't realize the consequence. They're sometimes old patients that say, well, I don't have any reason to do it. But instead in breast and ovarian cancer and even pancreatic cancer, we have about 0 refusal rates. So acceptance and I think information why to test is fundamental. And this involves all specialists. And
it's really important to emphasize this at the beginning. If it looks to the urologist as though this is really very important. Then, of course, when they go and talk to the medical oncologist about testing, they think, yeah, I know the medical oncologist is very keen, but they just want to give me some poison. And the answer is that the urologist didn't think it was important, and I knew them first. And so that becomes a problem. And it's really important that as a team we're coherent and give the same message out, that genetic testing is going to be very important for which particular groups?
Well, guidelines are quite uniform. So NCCN, EAU, ESMO in the end recommend germline testing and counseling in metastatic patients, but also already in localized high-risk patients.
The localized high-risk patients, can we qualify that at all? Because that's quite a big group these days. Is there any way of working out which ones are more likely to gain benefit?
Well, I mean, we always have also other negative features that the pathologist tells us, like cribriform, intraductal. And in the earlier guidelines of NCCN, there was also that risk factor with cribriform, intraductal that led sometime also to recommend it for intermediate risk patients with those features. But in the end, also to make it feasible to do the testing, they actually did it recommended now for the high risk patients. And these are patients that we know that have more aggressive disease, the higher Gleason score. So they have the biology behind it to also have the probability to have an HRR mutation.
So in summary, what 3 things would you say that urologists need to be cognizant of in terms of helping with genetic testing for prostate cancer?
I think it's important to do the family history. I mean, if you present the patient as a urologist at the tumor board, localized disease, but it comes up that he has a strong family history for typical tumors that are involved also with prostate cancer, or even 2 brothers, 1 father with prostate cancer, then genetic testing might be also indicated in intermediate or low risk. So I think family history is the main point where the urologist can contribute easily, giving information already. And then also be the partner in communicating in why and what's the benefit.
Thank you for listening to this episode of EAU Podcast. To keep up to date with prostate cancer developments, visit our educational platform, EuroOnco Prostate Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.